So guys, like I said, this patient was tracked by the students. I've just seen on the blood results that this patient is 66 years and it's a female. So like I said, that when the students came to me with this patient, remember I'm doing psychiatry at this moment. So these two students are doing family medicine. So they asked me if they could track a patient and then come and present to me, even though I was busy with psychiatry patients. I said, okay, it's fine. So when they came to me, like I said, this patient was labeled as uncontrolled hypertension, and she presented the previous day with in hypertensive crisis. Guys, please go and look for a video where I talk about hypertensive crisis. What is the actual blood pressure that the patient must have for you to say it's hypertensive crisis? But I'll just tell you now, they need to have a blood pressure of more than 160/110. So once a patient has got a blood pressure that is higher than this, that's hypertensive crisis. That's higher than this. And if it's hypertensive crisis, you need to decide, is it urgency or emergency? Right? And it depends on whether there is TOD or not. And I said emergency is when there is TOD, right? And urgency is when there is no TOD. And you know what TOD is? Target organ damage. And we have spoken about those in detail. So please go and look at that video. Okay. So so they came to me, this patient. So this patient was she had very high blood pressures that were higher than this. I can't remember the exact values, but when she came the following day for the, I don't know why she went and then came back. I really don't know why. But when we looked at the file, she had the a chest x-ray, UNEs, HB, A1C. I can't remember if urine was done there. So she was given amlodipine. Please guys, go and watch one of my videos where I talk about antihypertensives in detail. That video is my most successful video. It has got about 340 views. It's the most successful. People love that because I think I break the antihypertensives so nicely. It's easy to remember them. So please go and look at that. So this when I asked the patient, the students, what treatment is this patient on, they said the patient is on atenolol, 50 milligrams daily per hours. That was the only drug that the patient was on. So the x-ray that you saw me with the students trying to analyze and check and calculate the cardiothoracic ratio is the x-ray of this patient. Remember, for ethical reasons, we're not going to mention the patient's name and all of those things. So because what we are trying to do is trying to learn from all the patients that we see so that we become better doctors as we go along. So the UNEs luckily were normal for her, so she didn't have TOD in terms of the kidney, and this was also normal as well. This was not done. I can't remember this one being done. So I said to the students, guys, this patient has got a massive cardiomegaly of about, I think it was about 65 to 70%. And I said to them, if you guys, when you go back to the patient, please make sure that you take BNP blood and also lipogram for this patient, né? And then send me the sticker. So I was fortunate enough that I had nice students. They went, they did the blood, and then they sent me the code. When I checked the code yesterday, this is what I saw. The BNP of this patient, remember, when this patient came, there wasn't anything about her having heart failure symptoms, even though she had a cardiomegaly. The main thing that was a focus was the uncontrolled hypertension. But fortunately enough, the doctor who saw the patient send the patient for chest x-ray. And I said to the students that with this kind of cardiomegaly, this patient must have a high BNP. So let's do those bloods. So the BNP of this patient is 1285. That's the BNP of this patient. Remember, the cutoff value is 300. This is it's not age related. So a patient who's got a BNP that's more than 300, be worried. Be worried. And then there are values that are age dependent. So for someone, according to this, for someone these are lab values that we got from NHLS. So for someone who is less than 50, their BNP should not be less than 50. Their BNP should not be more than 450. If the patient is between 50 and 75, their BNP should not be more than 900. If it is more, then it means they've got heart failure, acute heart failure. If the patient is more than 75, then their BNP should not be more than 1000. 1000 what? I don't know. I think this is 1000. Yeah, shouldn't be more than 1000. I can't see my own writing. Okay, so guys, our patient is 66, so she's here, and her BNP is 1285, and then the cutoff according to age is 900. But the literature that you will read, they will tell you that if it's more than 300, that's a cutoff that is not age dependent, and that's the one that we use. So if you compare this and this, like this patient has got heart failure, guys. It's got heart failure. We're gonna talk about what's the correlation between heart failure and BNP. Let's talk about the other causes of a high BNP, right? The differentials of a high BNP. It's chronic kidney disease, and the reason for that is because when you've got chronic kidney disease, first of all, you've got a state of fluid overload, right? That's the first reason. And that fluid overload does affect the heart, even though you might be asymptomatic, but it does affect the heart because you've got fluid overload, because the osmoregulation of the kidney is affected. The other thing is that when you've got kidney disease, you are not excreting all the metabolites that are in the body the way you are supposed to be. Because remember, once you've got a hormone, once it's broken down, you should go and pee that out. Once you've got a drug, once it's been broken down, have its effect, you should pee it out. So when the BNP and all those things have been secreted, they stay longer because of the decreased glomerular filtration rate of the patient. So remember, when you've got a GFR of now less than 15, it means whatever that is in your blood is going to stay there for longer because you're not taking it out. Another is a pulmonary embolism, pulmonary hypertension, right? For us, the reason why we are so sure that this patient's got heart failure is because, but the number one cause of a high BNP, is heart failure. Think about heart failure before anything else. Because remember, the other things you can always diagnose them using other modalities. For instance, you can send a patient, you can do D-dimers here and send a patient for a CT angel, all that kind of a thing, to route a PE if you think that there's a PE. And also the short of breath is going to be more acute with a PE than with a heart failure, that type of a thing. And also, what convinces us is that this patient has got hypertension. Hypertension is a risk factor for congestive heart failure. She's got uncontrolled hypertension. She's got a massive cardiomegaly. Now she's got a BNP that is high. You see? So yeah. And also, okay, so now what's the correlation between the BNP and heart failure? Let's talk about that. So if this is our heart, these are our ventricles like that. So we've got cells here, the cardiomyocytes, these cells. Ne? So what happens is that let's take one or maybe a few of them. let's say they are this big at this point. When you've got fluid overload, the cardiomyocytes, they start to become bigger and bigger and bigger and bigger. And this is how you get cardiomegaly. They start because there are so many reasons why, mechanisms why, but one of them is that fluid inside. Remember, when you've got heart failure, after ejecting some blood, there's always blood that remains. And then the blood that remains is joined by the blood from the atria again. So there's forever a lot of blood that remains here, and that blood that stays there, the heart tries to accommodate it, and when it tries to accommodate that blood, I think it's called end diastolic volume. Yeah, it's called end diastolic volume. So it keeps increasing and increasing and increasing, and then the heart keeps and the fact that the heart has got to pump to pump harder to make sure that all the cells in the body, the tissues, are able to remain metabolically active. It puts a strain on these cardiomyocytes, and as they do that, they keep stretching and becoming bigger and becoming, just from this size, for instance, they keep becoming bigger and bigger. And in that process, for them, they think that they are doing you a justice by helping you. But in actual fact, once they become too big, they become floppy, and then you get now a reduced ejection fraction. So now you've got a full-blown heart failure. So now what I'm trying to say is, when these cardiomyocytes, they keep stretching and stretching and stretching and stretching and stretching, they secrete two types of hormones, the ANP and the BNP. Antinuretic peptide and brain natriuretic peptide. Remember, natriuretic refers to sodium. Natriuretic. So remember the physiology of what happens in the nephron. That's the nephron: descending loop, ascending loop, a distal convoluted tubule, proximal collecting duct, and calyxes. So what happens is that these hormones, they are secreted. The more the cardiomyocytes are stretching and dilating, they keep secreting this, because what this is trying to do is trying to say, okay, the reason why we are overstretched is because we've got a lot of water. So if we can secrete these hormones, then we are going to lose some water, and then we won't have to stretch so much. So this is how it happens. Once these the BNP and the NP are secreted in the blood, these are hormones. What they will do, they will force the sodium to remain inside the nephron, and they will force the sodium to remain inside the nephron and be excreted. So that's what these hormones want. They want they enhance the excretion of sodium, right? And once you have a lot of sodium inside here, chloride is gonna follow, and then you're gonna create a gradient. And once you have created that kind of because sodium chloride is osmotically active, water is gonna follow and enter here, so that it just goes out with the sodium chloride. And then in that process, you will lose sodium, but you will pull water in the process. And if you do this enough, you should be able to deal with the problem of fluid overload. So this is the principle. That's why these two hormones are being excreted. So once you do that, so the trigger for this, what I want you to get, guys, is that the trigger for these natriuretic peptides is overstretching of the cardiomyocytes. That's the trigger. So it makes sense that when you've got a heart failure patient, that their BNPs become high, because a patient who's got heart failure, they have fluid overload, and we know that they've got stretched cardiomyocytes, right? So that's why you get a high BNP with this kind of patients. If you watch this video that I told you about, guys, management of heart failure, there is a class of drugs that remember, when these two are excreted, they are later metabolized and broken down and deactivated by an enzyme. And these drugs, so which means these ones, they get a short half-life, so their effects are very minimal, right? So the drugs, what those drugs do in treating heart failure, they come in and block the action of this enzyme so that the BNP can be allowed to work longer. Like for instance, BNP, I'm just going to make an example because I want you to understand this. When the BNP is excreted, let's say if it's supposed to work, if each molecule is supposed to work 1 minute, and then the enzyme comes and break it. If you block that enzyme, it means, if you block the enzyme that breaks the BNP, it means you're going to allow the BNP to continue working. So maybe continue working for like 5 minutes. So you're going to have longer lasting effects of the BNP. And that's what you want with the heart failure patients. Okay. So there are 3 reasons. There are 3 things that BNP gives us. There are 3 instances where we can use BNP. The first one is to diagnose heart failure. And like I explained on the video, that when it comes to heart failure, according to the New York Heart Association, or is it heart failure? Can't remember it. But there's a classification there. There's a grade 1 heart failure, grade 2, grade 3, and then there's a grade 4. The patients that are grade 3 and grade 4 are patients, or it's class 3 and class 4. These patients are very sick patients that are very symptomatic and everything. A patient who's a class 1 is an asymptomatic patient. So you can have a patient who's got heart failure but asymptomatic and remains asymptomatic, right? So these kind of patients, if you really want to diagnose them, it means you rely on the BNP. Because the BNP, it's not specific, but it's very sensitive. It's very sensitive. So if you were, and then there are patients that will have, remember, when a patient is diagnosed with heart failure, the next thing that should be done is to send them for an echo. And why do we send a patient for an echo? It's because we want to decide, we want to grade the heart failure of this patient, sort of like classify it. Is it heart failure with reduced ejection fraction, or is it with a preserved ejection fraction? There's a reduced, there's a preserved, there's a third one that I'm forgetting, or maybe severely reduced, something like that. So a patient who's got a preserved ejection fraction is likely to be asymptomatic. So you're going to do an echo, and see that, oh, this patient's got a preserved ejection fraction. Most of them will be asymptomatic, and the only way you can sort of like monitor them is by BNP. So you can diagnose heart failure using the BNP. You can also guide management. You can also guide in management. What do I mean? If a patient who's got heart failure comes in and then they are sick enough for an admission, and then you do their BNP, and then you find that their BNP is like 1,800. If the management that you're gonna place this patient on is effective, their BNP should start going down and going down and going down, because, like I said, once you manage the patient, the fluid is gonna go out. The overload, the fluid overload symptoms are gonna go down as well, and when that happens, the heart is gonna at least stop now producing a lot of BNP. So it's supposed to go down. So if it's not going down and it continues to go up, it means there's something that is not going well in terms of your management. So you can guide management. You can also use it as a prognostic factor for prognosis. I mean, when you treat a patient who's got a BNP of 400 and then you treat a patient who's got a BNP of 2000, you can already tell that the one who's got a BNP of 200 is more sicker and is more likely, 2000 is more likely to have other complications of the heart failure as opposed to the one who just has got a BNP of 500. So that's what it basically means. I'm not sure if I'm leaving anything out. Oh, okay. One other thing that I wanna quickly talk about. The other thing that we did, but not in detail. I'm not gonna talk about this in detail. The other thing that I saw on this patient's blood is the what's this thing? The results for a lipogram, ne? So I asked the students that day to do a lipogram for this patient. So e cholesterol for this patient is 5.4. It's more than a 5. So, and the reason why I explained to them why I asked them to do cholesterol. I said to them that, remember, BP is equals to cardiac output multiplied by peripheral resistance. So if you've got a patient who's got an uncontrolled blood pressure, think about cholesterol. Why? Because cholesterol increases peripheral resistance. Never forget to do lipogram on a patient who's got a resistant or uncontrolled hypertension, because cholesterol causes an increased peripheral resistance. How? This is the lumen of a blood vessel. So if a plaque forms in here, it has reduced the size of the diameter of this lumen. So it means it's going to be harder now for blood to pass here because the lumen has been reduced. So that increases peripheral resistance. So which means if you've got a patient who's got cholesterol, you must manage the cholesterol so that you can deal with that plaque, so that they don't get into a situation whereby, because no matter the type of drugs you're gonna keep giving them on this side, as long as you have not dealt with this guy, they will continue to have a high blood pressure. But I just hope when the patient comes back, they will do his hair Framingham score to sort of like decide whether to start treatment or not. Remember, in terms of cholesterol, you need to look at the Framingham score and decide. And do that score, the risk scoring system, risk score, and then you decide from there. Our video is long, guys.